Now, all right. Good morning, everyone, and welcome to the State of Cannabis. My name is Susan Soares, and I'm the Executive Director of CARE. CARE is a 501c3 organization dedicated to creating awareness of the benefits of the cannabis plant. I do that by hosting conferences like this, authoring a children's book that is a tool to help grown-ups talk to children about cannabis, and I'm getting ready to relaunch the Green Oasis in new and exciting ways. I can't wait to announce it. Our first panel is Science in Cannabis, and will be moderated by one of my favorite moderators. Jehan, why don't you introduce yourself and take it from here?
Oh, thank you so much. My name is Jehan Marcoux. I've been in the cannabis research space for about 15 years. And I just want to say I'm so happy to see my panelists again. I love you guys. Thank you for agreeing to do this with me again. You all look wonderful today. I'm really excited. I think we're going to have a lot of fun today. I really enjoyed our panel. I know that the audience enjoyed it. And to the people who tuned in early, this is our gift to you. These are some of the best experts, medical professionals the industry has, and they're here for your benefit. If I wanted to consult with these people, I couldn't afford it. So they're here for you. Ask your questions, take advantage of it. You know who these people are. I'll introduce them as we ask questions. But you know, we're gonna discuss some cannabis research updates. There's some really cool stuff happening outside of the environment we're all living in right now. And of course, we will touch upon some of the new COVID cannabis research, but there are some really exciting updates that are going on, and I don't want to miss any of that. So we're gonna jump right in. All of our panelists are here, and the first thing I'd like to discuss is a statement from the American Heart Association. An article came out about cannabis and health, and Jordan, if you're ready, I'd like to send the first fastball to you. Tell us about this statement from the American Heart Association and, you know, your association, the Association of Cannabis Specialists. Is this in line with what your physicians are familiar with, what you teach and things like that?
Yes, as a matter of fact, you know, I think that it's the statement that they put out seems to be a well-crafted one and a thoughtful one. It's certain that within the cannabis industry, we might initially bristle because, of course, we as physicians tend to be fairly conservative about these things, and cardiologists perhaps even more so than the average physician. But in fact, you know, there are a number of effects that cannabis has on the heart and the cardiovascular system in general, much of which remains to be properly elucidated. But you know, what we're seeing is that there are some situations where patients who have heart disease of one type or another, who may then get cannabis treatment for some other issue, can be adversely affected by that cannabis in terms of their cardiovascular function. In its simplest terms, we know that cannabis, particularly in new users, we can promote a transient drop in blood pressure and a compensatory increase in heart rate. And where this becomes an issue, particularly in older folks, is that they may have some amount of not clinically evident, meaning they're not aware of it at this point, cardiac disease, coronary artery disease. But when you put them in that cardiac stress position via the cannabis, you may in fact exceed their ability to supply blood and oxygen to the heart, and you can have a heart attack. Excuse me. There's also some emerging literature of heart attacks in young people, 20, 30-year-olds, that may be related to cannabis mediated spasm in the coronary arteries that could then decrease blood flow, et cetera. That's, I think, a little bit more iffy, and I think a lot needs to be looked into. Many of the studies that look at the advent of heart attacks, both in the older folks and in these younger groups, are done via types of research that are suggestive but not conclusive. There's also some growing evidence that cannabis can cause a funny heart rhythm called atrial fibrillation. This is something that one needs to be aware of. Generally speaking, it's not something that I worry about much, but in the setting of people who have had damage to their heart and therefore it's not squeezing adequately, they may be fine until you give them cannabis, and cannabis, amongst other things, decreases the strength with which one's heart contracts. And if you have a normal heart, that's not a big deal. But if you have a weak heart, that can be a big deal. And I've seen an occasional patient end up in what we call congestive heart failure as a result. It's rare. And I have many patients who have histories of congestive heart failure. It's not an absolute contraindication, but it's something where we need to work, hand in hand with their cardiologist to make sure that we're all monitoring carefully. And at the first signs of trouble, we need to be able to intervene.
Thank you, Jordan, for that 30,000-foot view and helping us understand this article from the American Heart Association. We will put a link into the chat for you all in a second if you want to read that article. Following up to Jordan's comments, in the discussion about the need for research and that insight, I would like to go to Dr. Olga Kovalchuk, who's an expert on basic research. You may remember her CBD extract study that we discussed last time on cellular models. Dr. Kovalchuk, what would you like to add? What would you add to this conversation?
This is actually a very, very interesting article. And as Jordan just mentioned, way more research is needed. And I think in order for us to fully understand what exactly cannabis is doing, essentially to the cardiovascular system, I won't even go to the heart itself, right? Because cardiovascular system, kind of more in general, I think we really badly need way more mechanistic studies done on animal models. As we all know, cannabis is very, very, I shouldn't say very general term, but cannabis extract or cannabis, for example, that is used by people through smoking, has so many different components, right? It has THC, it has CBD, it has terpenes, it has other minor cannabinoids, and all of them can work either synergistically or antagonistically. The effects are actually tissue specific. So therefore, in order for us to fully understand what exactly is going on, we'd really need to now kind of dive into those mechanistic studies, because quite interestingly, from one of the collaborations that I have with one of my colleagues, I'll keep it very general because again, I didn't have his permission to disclose a lot of it, but we were actually working together on a grant proposal, actually thinking about one of the components of cannabis potentially being anti-arrhythmic, which is quite interesting and sort of quite, I would say to a certain degree, shouldn't say counterintuitive, but kind of in context, it would say this is the effect of cannabis global, right? Whereas certain cannabinoids may have different effects, but what they are doing is they actually using animal models and trying to understand the mechanisms. So I think before we can draw the conclusions, and I fully agree with what Jordan just said, we really need to have solid research established in this field, in many other fields.
Thank you, Dr. Kovalchuk. I'm going to go to someone I turn to discuss pharmacology and aspects of pharmacy. Dr. Tang, there's obviously medications out there people are taking for various things related to the CVS or might have an interaction with the cardiovascular system. What can you tell us about cannabis and some of those medications or activities that relate to cannabis and maybe some of those OTC drugs? What can you tell us about that?
There is some risk. In terms of taking the research and in vitro studies and the pharmacological parameters and properties that we know about cannabinoids, terpenoids, flavonoids, all the different phytochemicals in cannabis, we know how they will act at certain receptors. And we talked about the endocannabinoid system last time. But there's also this wide net that patients are casting when they're turning to cannabis to use it for symptom relief, for persistent symptoms that aren't responding to conventional therapy, and they're looking to it as an alternative. And with that whole plant medicine pharmacology in mind, there's a lot of different ways it can act on not only the endocannabinoid system, but cellular systems that have crosstalk because of G protein coupled receptors, and their pharmacology is a cascade of effects in neurotransmitter signaling pathway modulation. So there's a lot of fancy ways in saying like how our body works in terms of dopamine, serotonin, adenosine, acetylcholine. All of these pathways are going to be affected by the pharmacology of all those phytochemicals. And then that's something that has to be screened for preemptively, because a lot of patients not only are using cannabis and they're going to look for other herbals, supplements, over the counters, while they're also taking prescription medication. And in our healthcare system model currently, a lot of different practitioners, when we're talking about like cardiovascular specialists, could be seeing patients and treating a specific condition and giving them a drug that could have a potential drug-drug interaction depending on its metabolism pathway when taken by mouth. And then they might not be talking to another specialist that the patient is seeing. Like, does the patient have HIV/AIDS? Are they a patient with cancer? Are they seeing an oncologist? Do they have an autoimmune disorder, so they have to see a gastroenterologist? Like, they could be seeing so many other specialists with other medications that are being prescribed with a known risk. Some medications have what's called a black box warning, and that black box warning is a huge disclaimer. It notifies the practitioner and the patient up front about the real known risks with that drug, and it could have some cardiovascular clinical implications. Like, that prescription medication could be beneficial if that patient had a stroke, if they have high blood pressure. There's so many reasons they could be legitimately on that medication. But then when they're taking cannabis, or if they're going to take and introduce another herbal or supplement or over the counter, that's going to either block their metabolism enzymes and increase levels, so that either the medication, either CBD, it really is so finely nuanced and specific to what concentrations of certain medications will go up, so that increases the risk of clinical outcomes being adverse effects. And then it might also increase the metabolism of how enzymes will increasingly rapidly metabolize the drugs in the body, and the body doesn't differentiate drugs. Like, this is a prescription medication, this isn't over the counter. Like, a drug in your body is a drug. So like, we put that mental like categorization on ourselves as humans, but the body on a physiological level is like, okay, there's a drug, a metabolite acting at this receptor. Like, it's very black and white. So that is a real risk that patients don't even think of, because there's a common misconception that, oh, if I need this heart medication, then I also want to take this supplement that I heard about on the internet and I perceive natural to be safe, on top of taking cannabis, knowing that like if you're taking unintentionally too much THC, it leads to dysphoria. So it's a big problem. It's kind of going like under the radar if we don't have pharmacists interacting with medical cannabis patients to screen, to counsel. They need the proper training, the proper education. Communicating it to the practitioners is another next step that we already have. That's like a natural part of our medical model. And it's interesting because when I participate in dispensary or bud tender or dispensary associate training, I'll do like a true false trivia with them. Every time I ask them if there are drug-drug interactions with cannabis, everyone says no. So it's like, no, you guys have to tell the patients with whom you're interacting, or adult use consumers in the markets that are legal states, you have to tell them that they have to talk to their prescriber. They have to talk to a pharmacist. There are resources available that screen for this and educate healthcare providers, medical professionals, and researchers on the exact specific metabolism pathways that break down CBD, THC, and everything else.
Thank you, Monica. Really good advice. You know, cannabis by itself might not present much of a risk to the cardiovascular system, but as we add those other factors, whether it's medications or lifestyle, it gets a little more complicated. Unless, you know, I wanted to go to Dr. Apgar in a second, but Leslie, if you have something to contribute, otherwise I wanted to ask Jordan to close it out. But Leslie, do you have a comment on this study?
You know, Monica did a fabulous job reminding everyone that cannabis is actually medicine. And just because it is a plant-based source does not mean that it's not going to have a significant effect on the body. So while I am cautiously interpreting this data, because As Jordan mentioned, it's not a great study. It's not a well-designed study yet. I think it's so important to remind everybody that cannabis can have negative effects. And we just need to, I think it's humbling for all of us, right? Because I'm fairly comfortable being in this every day, up to my eyeballs with all the patients that I see. It's a nice reminder to really take it very seriously to everybody who's listening. It is a real medicine.
Thank you. Well, this discussion began with Dr. Jordan Tischler. I might as well end with him before we go on to our next research topic. Dr. Tischler, final thoughts on this segment?
I just wanted to comment. I think that Monica and Leslie really hit the nail on the head about the drug-drug interactions, which had been on my agenda to mention. And I think that, you know, what we need to understand, and really Monica kind of got at this, is that the medications from cannabis will have interactions. And what's really not understood, you know, as she said, most of the bud tenders think there are no interactions. I think most of the world thinks that as well. And the thing that probably would surprise most people the most is that it's CBD particularly that is most commonly associated with those kinds of interactions. And where we're talking about the cardiovascular system, there are a number of meds in that category. So warfarin, which is a blood thinner, is one, which thankfully we can measure the level of and adjust. But there's another one that's commonly used called clopidogrel or Plavix, and that's used a lot after people get stents placed in their coronary arteries to keep the artery open. And the problem is those stents can cause a clot, which would then shut down the artery and potentially cause a fatal heart attack if we don't give this blood thinner. But this blood thinner can be affected by CBD, and you know, we don't know what that could do, but the risk there is that we could cause major problems. There are a bunch of other drugs. Amiodarone is a classic example of a medication given to control heart rhythms, and it's a wonderful drug, but it's dangerous if it gets outside the realm of where it's safe, and CBD interacts with that. This week, as a matter of fact, I came across my first THC interaction in a real setting with a medication that isn't a heart medication. It's an Alzheimer's medication called Aricept. But thankfully, most drugs don't interact tremendously with THC, but really do interact with CBD. And so, you know, again, as a society, as well as an industry and as practitioners, we really kind of have to open our eyes to this so that we don't stumble blindly into creating problems. And thank you.
Thank you, Jordan. You know, to transition, one of the other aspects of health and cardiovascular health is exercise and fitness. And a recent study published in last month from the American Journal of Health and Behavior looked at exercise intervention outcomes in cannabis users and non-users. And Dr. Apgar, you know, you're an MD who also, you know, works on the front lines in access to medical cannabis. Could you tell us a little bit about your thoughts on this study and maybe some of the implications and maybe some of your experience working with patients who are using cannabis and trying to be active?
Sure. So first, let me start off by stating that cannabis is not cannabis is not cannabis. So it's very hard to have an intelligent conversation about any of this, right? Because a chemovar is not the same. And I practice medicine in that I'm always advocating for higher doses of CBD compared to lower doses of THC. Not high doses of CBD like to the panel here, what we would consider high doses, but to the lay public and to the other educated out there, I always am trying to give higher doses of CBD. So I always read studies like this and take it with a grain of salt because I wonder what that actually would look like if you were able to define what patients were taking into their bodies. But I was happy to see that that cannabis use certainly did not have a negative impact on exercise, and in fact, it helped fitness. So in my practice, I have patients who ask me all the time, what should I do? I'm about ready to go to the gym, or I just played a basketball game back in the days when we used to be able to play basketball in person. And now I'm in pain. What do I do? I have a number of patients who actually medicate before and after they exercise, and it improves their mental status. It improves, they say, their ability to recover after. It lessens their muscle pain. And for some of my patients who have a mental block about going to the gym or being active in any capacity, going outside for a walk around the lake, what have you, it sometimes is just what they need to be motivated enough to do something that, as a physician, I would say is a healthy enterprise. We should all get out and walk. We should all be active in some capacity. So when I look at studies like this, I look at things kind of globally, because obviously exercise has lots of benefits as far as mental health goes, and that is a big problem right now with COVID. I think I told you guys last time our business was up at least 50% because everybody is so stressed out and they can't sleep, and that, when is this going to end? And there's a lot of sadness in the world. So I guess my take home is that it certainly didn't seem to hurt anybody. I would love to see studies that actually break down what cannabinoids were ingested and what the effects were based on those ratios. But I would also say whatever helps you get through your days and nights right now. And if cannabis is what you need to be motivated to exercise, and if cannabis is what you need to help you recover, I'm all for it.
Thank you. Just a quick follow-up before we go to the rest of the panelists. You have a passion and an expertise in looking at some of the gender differences in cannabinoid action. So are male and female exercise enthusiasts endorsing or associating cannabis with the same thing? Like, for example, is maybe male populations like saying they use it for energy, whereas maybe it's used in recovery in female? I mean, I'm just kind of curious if you've seen any trends just from your experience.
I love this question. And I will say that I don't know how much of this is socially mediated, that it's maybe more socially acceptable for men to smoke or to imbibe cannabis. I don't know, because I think as women, we're still catching up to this male-dominated market historically. Not anymore, obviously. So I will tell you that the men seem to talk to me much more about recovery. And I'm getting more of an emotional state with the women, because obviously we're such emotional creatures. It's the way we're wired. But they almost are using it as an antidepressive and something to motivate them to go to the gym. So just in my own patient population, obviously this is not a study, that's the feedback I'm getting from the patients, that I'm not getting women who are saying I'm using it for recovery. But again, gender differences, perhaps those women are not going and hitting the iron as hard as perhaps the male counterparts are. So perhaps, they're not using the gym in the same way, or they're not using their activity in the same way to be able to draw conclusions or comparisons, I should say.
Great, thank you. Gosh, I have so many talented panelists. I don't know who to go to next. How about Jordan, then Monica, and then Olga, if you'd like to add anything. No pressure, but Jordan, what would you like to add?
Well, I'll just be brief. But, I've written fairly extensively on this particular topic, and everything that Leslie has mentioned is absolutely true. I would bring up that maybe the women who are pre-medicating are also benefiting on the warm down and recovery, and are not thinking of it in quite those dichotomous terms. The thing that comes up a lot on this subject that I think is worth mentioning is the context of that exercise. So Leslie mentioned getting out and walking, which is wonderful. And she also mentioned hitting the gym, which is also a good thing. But then I've been asked, particularly in the context of sort of sports related magazines, about sort of more aggressive types of exercise, like things like rock climbing, in-town cycling, skydiving, and that sort of thing. And I think that this is an area where, again, the idea of cannabis being useful for motivation and for recovery, absolutely. But we also, as practitioners and advisors, probably also have to have a little bit of a mind to the risk that's involved. And I think that, climbing up the sheer face of a mountain while stoned is probably not necessarily the best thing to do, and probably not something we should be advising. So the context of the exercise, I think, is very important as well. And I think I'll just leave it there.
Thank you, Jordan. I think that's a good point. The context of the exercise, also high impact, low impact. There's a lot of factors there. I definitely would be interested in comparing different types of exercise? Is it getting on a treadmill and running, or are you lifting weights? Are you swimming? What type of activity? I'd like to go to Dr. Tang. You know, cannabis has a lot of stigma, and as if someone's out there training pharmacists, you know, stranger to this, could you talk about the stigma around cannabis and exercise? Is information like this helping or hurting?
I think it's a good milestone to indicate in terms of the divide that we have among like different age groups and different users, whether patients or adult use consumers. I think when I'm in a dispensary and counseling patients, they're like, a lot of times I'll hear, I don't want to get high. And they're like, I don't want to feel the couch lock. I don't want to feel dizzy and confused. But then also after we go through the counseling and I explain to them the differences between chemotypes and chemovars, how it's important to understand cannabinoid concentration of the product they select, what the THC and CBD concentrations, and then considering everything else that isn't tested or labeled. We talk about what would be appropriate for them for daytime use or when they want to be alert and oriented, whenever they're doing other physical activity. And then after they'll be like, okay, so I haven't hit my quantity yet, and now I want a fun option so that I can have it at night and I can feel the high and I can go to bed. And I'm walking them through like, okay, I can hear your concern that you don't want to feel high all the time when you want to be focused. But also at the same time, because patients have PTSD, because they have anxiety, they also sometimes do want, in the appropriate setting and time, to feel euphoria. And I think offering them that space where they can safely talk about, this is when I want to be feeling a euphoric, uplifted sensation, and when I don't want to, working with them in that capacity, explaining to them potency, onset of action, duration of action, how through an inhalation method, there'll be seconds to minutes versus with an oral administration with delay time. We'll factor into, if they're exercising, how beneficial and effective that is. Because I also, in the back of my mind, are thinking when I'm talking to an older patient, if they're doing low intensity exercise, they want to take their cannabinoid-based product before they do group water aerobics or a group like dance class. And I'm like, that's great for you. But also looking at the medication that you're taking, and before you select the product that you're about to pick, I wouldn't recommend a high THC because of the risk for fall, of the risk, like once it hits, if you're taking oral administration, it's going to be a more potent metabolite, and that's going to last longer in the body. So all these factors are something to consider in a very patient-specific paradigm, like looking at the individual and really customizing that counseling, making sure that they understand the risks and the benefits of both. And it helps, I think, bridge the stigma, because it's happening with a lot of people. Medical providers who I train, they don't understand, or they don't initially get introduced to the endocannabinoid system. I tell them about how in exercise, we know about the runner's high, and we know about endorphins being endogenous opioids. That's endocannabinoids, anandamide, 2-arachidonoglycerol, like endogenous cannabinoids. There you go. That's like the intersectionality of science to shatter stigma. Like,
yeah, I love the fact that you brought up the runner's high, because it's not called runner's sobriety, right? There's a rewarding mechanism for exercising.
Right.
It was a great explanation.
Yeah, it bridges it. It bridges it with science. Like, don't be afraid. Don't stigmatize it. I understand your concerns and your fear, but if you can understand the science, then you can understand how to keep your patient safe from the medical provider's perspective.
Wonderful. You guys are killing it today. I'm so happy. Dr. Kolachek, tell us your perspective on this research, and then after this, I'd actually like to come back to you to ask a question about a recent bone study.
Okay, so well, what I can add to this is that, and it was like absolutely great. Monica just essentially pretty much phrased what I wanted to say. Lack of information generates fear. Fear generates rejection. And therefore, essentially these panels that we're doing, promoting, relaying information to the general public as well as to research community and medical community is actually crucial. Because when we're talking about exercise, vigorous exercise, and what do? You actually increase inflammation in your body. And therefore, for example, applying some cannabis or using cannabis can mitigate that, actually inflammation that is going on, right? So, which is, I think, very, very, very important contribution. On the other hand, yes, there is runner's high. There is that, endorphin, there is that general boost. But the other thing, and I've heard it from essentially a lot of colleagues and friends who are vigorous exercisers, because I actually work out like probably crazy every day, but anyways, so what people say that high THC products, one very important thing you need to know is that some high THC products give you, for the lack of better scientific term, munches. So, which obviously, if taken in the wrong time of the day, could it could backfire. So if you're trying to stabilize the weight, if you're trying to, essentially stabilize your body mass, stabilize your level of body fat, and you're exercising and you're having a high THC product that all of a sudden, promotes you, kind of munching up on a whole bunch of high calorie foods in the end of the day, that could sabotage the efforts and it could bring that inflammation back in the body. So again, it has to be a really precision medicine approach. It has to be personalized. It has to be tailored to each person. And essentially, again, if done right, it works.
Thank you. Terrific. So I'm gonna transition a little bit to a completely unrelated but maybe related topic, and that's bone healing. In exercise, as you're maintaining bone health, you get microfractures and those are healed. But occasionally you might go a little too aggressive in your exercise and get a minor fracture or other bone injury. Osteoblasts, the bone making cells, come from our stem cells and are differentiated slowly through a series of processes. A recent study out of, I think it's Environmental Toxicology, published in July 2020, researchers looked at CBD and found that it helped turn immature bone cells into osteoblasts, and that cannabidiol might be this novel therapeutic option for bone generation. Dr. Kovalchuk, you're our resident molecular biologist on the panel. You have a lot of experience with cell models. Could you tell us a little bit about your opinions about this type of research? Do you feel that there's a big promise here for CBD in bone healing?
I actually really liked the study. When I looked at it, I was like, it's definitely, I should say, trailblazing study. And because it's, again, one of the new aspects of where CBD, again, can be involved. It is really what's most important, again, it's, as I said, the essential trailblazers doing it the right way. What we really need to understand right now is, from my standpoint, number one, molecularly, we need to exactly define precisely which pathways we are using. Because again, there is always that fine line, and again, it's just me being devil's advocate, right? In promoting bone growth, right? And at which point it becomes an issue, an issue. You know what I mean? So we don't want to promote it out of control. So we want to figure out, is it, and for that reason, I like the word modulation. So what I see oftentimes in our experiments, and again, I may be just essentially biased because I really am interested in overall the effects of cannabis, and I think it has a lot of potential, right? So, but we can never say cannabis increases X and decreases Y. At least to me, it feels like it brings it to the status quo. It brings that to that, golden norm, if we can define the norm, right? So it modulates the process and brings it back to that, best possible state. But the fact that CBD can be used potentially, we need, of course, more studies in it, in essentially bone regeneration, osteoblast differentiation, is actually very promising because what it has to be coupled with aging studies, because this is where we have the most need. So in our aging population, when a person falls, we all know how difficult it is to heal that bone, right? And how oftentimes individuals after a fall, unfortunately, they just pass away, right? So why? Because that bone won't heal. And if we have more studies done in animal models and we prove that probably, I think, has a significant amount of potential to be further advanced into clinical trials as to what will happen if we actually provide CBDs in therapeutic combinations. Of course, if it withstands further preclinical work in bone healing, especially in elderly, because I would see that age group as most, where the most need is, because we need to have something that could really improve bone healing. And of course, we also need to understand again molecularly, and we also need to see how that will work in males and females. Again, because metabolism is slightly different in males and females. Again, bone healing because of hormonal changes in our bodies. So that also needs to be brought in. But overall, I know I really applaud that group, and they really opened a very, very interesting area of research. Kudos to them, and I want to see more.
Excellent. The bone issue you brought up is so important, and I really liked what you said about the balance. We have the osteoblasts that make bone cells, we have osteoclasts that dissolve bone cells, and it's the interplay and balance of the two that replenishes our skeleton, our entire skeleton, every 8 to 10 years. It's kind of amazing to think about this process. And if you start to make too much bone, that's not good. If you have dense bones like Wolverine from X-Men, that's actually more brittle. And so you have to have this kind of perfect balance between making bone and dissolving bone. But CBD might just be one of the many tools we have to target bone health. Dr. Apgar, are there other cannabinoids you would be interested in seeing explored for bone health, or are there other compounds that you have read about that might also be beneficial?
Well, as Olga mentioned so beautifully, the older population, it's so important to take care of them and pay attention to them, and also women. So obviously, as an OBGYN, I have a special interest in taking care of women, especially as they start to lose estrogen and they start to deal with bone loss. And we, for a long time, did the bisphosphonates, and we were realizing, hey, we're building bone, but it's brittle bone, and is that of benefit or not? So your point is so well taken, that it's the beautiful balance of osteoblast and osteoclast activity to get the perfect density of bone. So important. So I know in some of my reading, and I'm going to absolutely rely on my panelists, my very smart panelists for this, but I think it was CBDV, the 3-carbon chain, that they had seen some bone remodeling in. And so for me and for Gina, who are developing products for women, we have a special interest in looking at those 3-carbon chain versions of the cannabinoids, because I think they're underutilized. And obviously people know what THCV does, but maybe somebody knows if CBDV is also a potential to look at as far as bone building.
I have seen some preliminary studies on it from like international sources, but it's they're small studies, limited, and it's from the in vitro level, so cellular in a petri dish. And with translational medicine, it'll be another hurdle to overcome in seeing it actually play out in animal models and in humans, because I've had studies cited where they're like, oh, they found it in mice, and I was like, yeah, but humans are different. Like, that's promising, but we still have a bit of a ways to go. So I'm also excited about CBDV, THCV as well.
And I think we're in consensus that the a lot of cannabinoids pass the first test. There's some sort of beneficial effect in the screen that justifies further and more complicated research. And yeah, I think CBDV and some of these other propyl analogs, as Leslie pointed out, warrant further research. They're very interesting compounds that this is the first time in human history people are actually consuming them in significant amounts. Jordan, you've been quiet for a while. What are your thoughts on this study?
Well, I think that one thing about this study that's actually really interesting to me is that it's not the first study of its type. It's actually a follow-up to a study that was done, actually a pair of studies that were done in Israel about 3 years ago. And the thing that's really interesting and exciting to me about this is so much of this early literature is kind of like, look, we did this study and here are our results. It's the first of its type. And that's interesting and novel. But the way science works, of course, is when a study is done, then it needs to be repeated and see if it's repeatable. And here we have something where we're starting to see that repetition come in and actual confirmation. But I think that, Dr. Apgar's point is really well taken, that it's a long way, and I guess Monica said this as well, that it's a long way from test tube to human being. And the bisphosphonates like alendronate that Dr. Apgar had mentioned is a great example, because, not only did we find that in certain circumstances it was building brittle bone, but it depends upon which bones we're talking about. So, you know, the bisphosphonates have shown some ongoing and repeatable benefit for spine demineralization, but not so much for hip demineralization. And so, you know, and we've learned over 20 odd years, you know, how to use those medications more appropriately and in a more refined sense. So, you know, not only do we have to get past the lab here and into humans, but we really have to think about, you know, each bone that's at risk of injury here is not necessarily the same. And again, as pointed out, it's not necessarily the same in women as it is in men. You know, women have a significantly higher risk of hip fracture and spine fractures than men do, largely because of the starting amount of calcium and then the hormonal changes through menopause. But the point being that there's a lot of work to be done here, and it's going to be very exciting as we wend our way through that.
Thank you. If there aren't any more follow-ups to the bone, I'd like to just rapid fire some of the audience questions we're getting now. It is a grab bag of topics. So if I just can get a thumbs up from my panelists, if you're ready for a little Q&A. Okay, great, awesome. All right, here's one straight out of left field. A very interesting question. Has anyone looked at the difference between organic and chem-grown cannabis? I assume that's maybe something like hydroponic or more chemical-heavy agriculture. And Leslie Fry says, I personally feel a heightened heart rate due to some chem-grown flowers. Is this a subjective effect? Could there be something here? Personally, you know, I've seen some research that shows that depending how you grow cannabis, indoors versus outdoors, what fertilizers and treatments you use, it can have a much higher nitrogen content that it was released when the product is combusted. I'm not sure if that's, you know, enough to trigger a heart rate. THC does have its own effects on heart. Any thoughts, gut feelings, reactions to this, panelists? Any comments? Dr. Apgar, let's go to you first.
Okay, so huge, great question. Know what's in your cannabis, right? So for some of you guys in California, it is a relatively recent development that you have what we would consider adequate testing to see what it actually is. So depending on where this individual is in the country, you'd be amazed how differently different states mandate the testing and what pesticides are acceptable and what pesticides are not acceptable to be using on your plant. So it may not be the cannabis so much as like this viewer is suggesting, it's the conditions in which that cannabis was grown. So it's such an important question. Here in Maryland, we had a grow out of the gate who was, I'm going to say, unfairly criticized and really taken to task for using what turns out to be an approved pesticide in Maryland. But I mean, Monica could probably talk about this too, but what are these things doing to our bodies and in what ways? So who knows what it is that is potentially causing people to have reactions. But when I got the approved list of things that were okay to be putting on this cannabis, I was like, whoa, that's a lot. Now, obviously everything is tested here in Maryland, and I know that, you know, as far as residual pesticides and residual solvents and all of that, it falls within the normal limits, but our bodies can be fairly sensitive, and what might be fine for you might not be fine for me. So I think it's a really important question to make sure that we're reading labels and that we're making the growers do things the way that they need to be doing in the ways that we feel are the most safe.
Thank you. I'm going to go to Jordan and then Olga while Monica formulates a potential response to Leslie's question about those interactions. No pressure, Monica. You've been really knocking it out of the park with the pharmacology, so feel free to relax if you want. Dr. Tischler, comments on this practice. Is this something that physicians think about, how cannabis is grown?
Probably not, or not adequately. I certainly do. You know, again, I think I would really second Dr. Apgar's remarks about cannabis testing being super important and also wildly variable from state to state. The regulations in Arizona and Colorado, for example, are just pitifully inadequate compared to, say, Maryland or Massachusetts. I think actually at the moment, Massachusetts has probably some of the best testing regulations. the likelihood of it being something as simple as overall nitrogen levels, I think, is probably not likely to be the culprit, but there are so many other aspects that are involved. The other thing I know, because one of my best friends from childhood is an organic farmer, is that not saying something is organic doesn't necessarily guarantee us any specificity. And so there are some national standards, but I don't know that those have been adequately applied to the cannabis grow area. Certainly California is going in that direction. I think that ultimately there are a lot of wrong ways to grow cannabis, unfortunately. And it's very easy. And this is one of the areas, not to change the subject completely, but I worry a lot about home grows. I think that the fundamental concept of growing your own cannabis is great, but it's very easy if you treat them like tomatoes, which is kind of the conventional wisdom, to end up with cannabis that absorbs a lot of heavy metals, in particular, like lead and arsenic and antimony from common potting soil. And of course, if people grow themselves, then they don't necessarily get it tested and they can ingest a whole lot of things. And I've actually seen this come up clinically. And so one of the policy shifts that I'd like to see over time is for us to figure out a way to incentivize home growers to get their stuff tested the way we require it of the dispensaries. And I've spent a fair amount of time trying to figure out what those incentives are. They're tough, but I think, because you don't want to be too punitive about it either. You really want to just make it so that it seems like the right thing to do, and people are therefore sort of inclined to do it for their own well-being without it being like, you'll get fined if you don't. But the general gist of it here is to know what's in your cannabis as best as we can.
Great.
Thank
And I just
you.
want to remind, thank you, Jordan. That was really good. Just want to remind panelists, we have a little over 10 minutes left. So I want to, if we can pick up the pace, get the heart rate going a little bit. Dr. Kovalchuk, I'd like to get your thoughts on this question. Then, of course, to Monica Tang.
Well, this actually is a really great question, and I very much liked what Jordan just said. The interesting aspect of it, as me years ago, I did a postdoc in one of the big companies that was actually in Syngenta doing the studies of health effects of pesticides. So, it's a very painful aspect. And actually, a lot of pesticides can definitely be extracted in together with whatever we extract from the plants. They are readily available there. So therefore, I think, yes, Massachusetts has wonderful regulations. In Europe, actually, it's almost customer driven. So in Europe, if it's not organic, people won't even consider it a medicine. It ought to be grown under this strictest organic thing. And one more interesting aspect that we in our lab just recently discovered, and that paper was just accepted for publication, it should come up hopefully fairly soon, that actually the other thing that actually does make a big difference is whether or not that flower has been irradiated. If we have done extracts from irradiated flowers and extracts from unirradiated flowers, and it's very different. So therefore we can say if it's treated, we need to study it, but again, the cleaner, the better.
Great point. The irradiation studies and just their effect on terpene levels alone gives you it's a little head scratching. Even though it's commonly used in agriculture that's shipped between countries, maybe it's not great to use on medicine. Dr. Tang, would you like to jump in here? I know Leslie put a little pressure on you.
I love it. Thank you. I mean, I love my fellow panelists. Everyone had such amazing insights. So where I want to, I guess, tie it in together and kind of bring it full circle is we're talking about product-specific considerations in terms of the importance of testing. And then there's still the irregularity around standardized testing and the efficacy of testing. What cannabinoid concentrations are you testing for? Are you testing for the acidic cannabinoids? Are you even going to test for terpenoids? So let me go on a tangent on that because that just makes me so mad about the irregularities and requirements around it. But pivoting on not only a product-specific platform for prioritizing the product of cannabis that you're considering, it's also going to be patient-specific in how individuals based on age, race, gender have different rates of metabolism. And the endocannabinoid system is always changing. So when we're bringing in pesticides, in terms of the pesticides that are potentially, while they're being tested on products from the legal market, patients and adult use consumers might be getting it from another source, a source that doesn't have third-party testing safety net to ensure that it isn't contaminated with pesticides. So that's a real risk that is important for educating people on in general, because some issues around not only pesticide, like adulteration, contamination concerns, is still that there's a lot of confusion and conflation about K2 and spice and synthetic cannabinoids and how they can be on plant, herbal, botanical cannabis products if it's from an unreliable source, someone who's trying to undercut the market and inflate sales. Is that because those have real risks, real potential harm issues on top of like not only just consuming untested severe concentrations of pesticides. So that's something I think about in terms of how metabolism can change, because I'm also thinking of it in like a holistic patient perspective, going back to, depending on the type of patient, is this a cancer patient? Are they undergoing chemotherapy, radiation? What is their treatment? And then this also ties into the bone density conversation with like, so many drugs will reduce bone mineral density. They'll affect it in so many ways, whether it's long-term use, whether it's injectable biologics, whether it's taken by mouth. There's so many factors to consider. So it's not like an individual case for the patient where it's like that baseline, heavy concentrations of pesticides will be harmful for sure. And then for that individual patient, again, factoring in age, gender, race, everyone has different rates of metabolism that are going to be influenced by the drugs that they're taking, and then how they personally, individually break down cannabis changes. So, I mean, I could keep going, but considering time.
I know you could. I'm looking forward to Monica, the textbook, being published sometime soon, because it would be so helpful for folks like me to be able to really have this information at our fingertips. You know, I want to transition a little bit. First of all, give you guys just a second to rest your brains and saying we're getting a lot of good feedback from the audience. You know, Kara Bradford has said this has been one of her favorite panels ever at any conference. It's been super helpful. We've gotten other questions coming in that are just like, great panel. So this is really going well. But, you know, I promised the audience we would talk a little bit about COVID, but I want to talk about a little bit more on a philosophical side. Now, one of someone I really admire is actually watching this webinar, David Ostro, who's, you know, a research physician who's done work in the HIV/AIDS space with the National Institutes of Mental Health. He had a question about sort of conspiracy theories around COVID. And so this is not real, it is related to cannabis, but it isn't. I think what, you know, kind of what he's getting is how should people address when they're confronted with misinformation and misconceptions, much like with HIV/AIDS and what treatments worked and was it created in a lab and stuff that's just like completely nonsense today that we look back and we're like, holy cow, what were you thinking? As health professionals, what advice can you give to people navigating these COVID conspiracy theories and scientific information? Any philosophical guidance you can offer people? Dr. Kovalchuk, you know, you've published in this space, the CBD and extract CBD study. You know, you're no stranger to people having misconceptions about data. So please share with us your thoughts.
Totally. I mean, and again, I'd repeat what I said before. That is why having conferences like this is really important. I wish there were panels like this run for COVID where people can tune in and listen, because lack of information generates fear. Fear generates either rejection or a conspiracy theory that, you know, some reptiloids from God knows where come in and are going to exterminate us, right? So, and the best way to address those is to actually, well, first, yes, I understand you're fearful. And this is legit. It's legit for people to be fearful in this situation, aren't we all, right? But say, look, from what I know, that's what I know, and I don't know more, so I will not speculate on what I do not know, right? So, and with us, for example, when we just started working on cannabis and COVID, again, you know, there were lots of questions, and one thing we had to do, and boy, did we work hard. As soon as the lab opened up, a little bit, we could have more than 2 people in the lab. We started working really hard to get more and more data. And we had to come up with this much additional experiments to actually, reconfirm and prove everything. And this is the other way we as scientists should be acting. People asking questions, show more data, invest in more data, and essentially say, look, yes, this was our initial study. This is proof. This is another proof. The onus is on us as scientists to provide more proof, and again, to provide information.
Thank you, Dr. Wood. And I agree completely with that. And another thing I would just add is, in addition to the data and the information people are presenting to you, I always like to think about, well, how was it generated? Because sometimes the methods are really more important than the results. They have different strengths and different weights. Dr. Jordan, are you ready?
I just want to add my favorite quote, right? It's for Abraham Lincoln, right? He says, "Don't believe everything you read on the internet."
Yes, and I think Albert Einstein said the same thing. People make memes about him saying things he never said. That's a good one. Dr. Apgar, I wanted to turn to you about this. You're on the front lines with patients coming in, and I'm sure they have all sorts of questions about this mysterious respiratory illness in cannabis. What are your thoughts about this? And if you can comment on that COVID article I shared from the MCBI, please share your thoughts.
Sure. So I'm oftentimes the only voice of reason in the room, and it's exhausting. I need to go on vacation because I've been the scientist since COVID started. So I'm a zoology major, and I had a particularly interesting background, so that I really feel like I had a fairly robust knowledge of zoonotic infections. My parasitology was coming back to haunt me. We did theoretical conversations about this. Being in the DC area, I've got the DoD, I've got the NSA, I've got all my people around me. So as far as the conspiracy thing goes, I mean, I could certainly have very interesting conversations with you guys offline, but our job as physicians is to compile the information, to make sense of it, and then to distribute it in a meaningful way that patients can understand. So for me, because we don't have great leadership as far as the management of this goes, and I'll just leave it at that, the doctors on the front lines are all scrambling around and trying to do the best that they can and sharing whatever data they have. So I happily am part of some of these chats with experts all over the world, and we share information together, and we kind of come up with best practice. And if we find an interesting article, we try and share that. And so that's what I'm trying to do, is basically distill that down. So from all of the other experts in the world, I'm trying to distill that information down and present it to patients in a way that they can understand. It's not it's not made up. This is a real virus. There's actually 100 that the guys in the Defense Department are looking at right now, all kinds of zoonotic infections that can cross because our population is expanding into these poor bats' territory, and they have nothing left to do but share their diseases with us. And it's just the tip of the iceberg. So funny enough, a little aside, this first round of vaccines is actually ultimately going to be a trial run for all the diseases that come later. So buckle up, guys. This is going to be a long journey. And so how do we get through it? We boost our immunity the best that we can, right? And how can we boost our immunity? Well, potentially through cannabis, as some of these studies are showing, like the one that you talked to us about. Certainly, if you take the individual components of cannabis apart and you look at them individually, they have bacteriostatic, they have antifungal, they have bacteria or virucidal effects, and we love that. And anecdotally, last time you guys asked me, you said, hey, what are you guys seeing there in your dispensary, Les? Are you seeing patients with COVID? And I'm not really seeing patients with COVID. So listen, that's no study. That's just me observing what's happening. But a lot of patients on our chats, on our Facebook groups or whatever, are all kind of talking amongst themselves. Hey, have you guys tested positive for COVID? Have you tested positive for COVID? It's not a study, guys, but I'm certainly seeing an association that cannabis users are not necessarily getting as sick as others. It would be lovely that Gina and I laugh all the time. Wouldn't it be hysterical if it turns out that cannabis is actually either prophylaxis or treatment for COVID? Like, what a beautiful thing. But, you know, I think it's one aspect to put into your armamentarium of all of the tools in your toolkit of things that you can do to stay healthy. You know, get some sunshine, get some vitamin D, get some zinc, get some cannabis potentially.
Thank you, Dr. Hepgart. I just want to let everyone know we're not on Marku time anymore, but Susan, our great MC in the cloud, has graciously given us another 5 minutes. I just got a great question in from the audience, and I want to open up to panelists. And then after this question, I just want to go to each of you to the quick kind of closing statement, anything you want to talk about, upcoming speaking events, a call to action. But, you know, I was wondering why I was talking about the Heart Association and cardiovascular research and COVID, and Ron Shapira put it together for us. You know, his question is, has the group dealt with apparent unexplained intermittent heightened heart attack or heart rates during COVID? He says he's experienced it himself. Doctor had multiple patients tell him they did as well. So he's asking to kind of give an assessment of the potential risk for THC to further increase heart rates. You know, he experienced that reaction, you know, with COVID, and he experienced an increased heart rate during the course of the infection. So any comments there? I mean, to me, this seems similar to a drug-drug interaction, and I would say let's go to Monica and then Olga. Did I scare Monica? Did she leave? Dr. Kovalchuk, are you ready to comment?
Yes. So what I can comment on this is we need to mechanistically understand what's the culprit. Is it CBD, THC, or the COVID itself? Because COVID, as we now know, the virus affects endothelial cells. It affects vascular endothelial cells. So essentially, it's not just a lung tropic virus. It actually affects the heart muscle itself, according to as well as it also affects vascular endothelial cells. And sometimes people can be not very symptomatic, but the virus affects those cells. And we are only starting to learn now what exactly is it doing. And in this case, it may be that a person was taking CBD or THC, and for example, had COVID, they may, because after our papers, we had a lot of people contacting us and saying, my patients who were taking CBD were, you know, less affected or had milder disease, right? But that may be a coincidence that the disease manifestation was milder, but the virus can still be highly tropic to the vascular endothelial cells and doing its wrong job there. So we can't exclude that mechanism as well. So we need to kind of dig deeper there.
Thank you, Dr. Kovalchuk. There's a question about the cell type in the chat. If you could type it in for Leslie. Oh, thank you, Jordan. Monica, you were about to say something, and then poof, you did the disappearing act. so real quickly, 30 seconds. Then we're gonna go to Jordan. We got to wrap up.
Yeah, bear in mind that cannabinoids are lipophilic, meaning that they're fat soluble. So the way that they deposit in the body is that even if it depends on how frequently, you use cannabis and cannabinoids, the route of administration in addition to the frequency and also the potency, because they will deposit in the fats of our body. Every single person has fat. And BMI is even on its own not always the most accurate marker to gauge in terms of like fat distribution and muscle, because BMI can fluctuate for athletes to lay individuals to and different genders and races and ages. But because it has such a long, in terms of depositing in the body, rate of metabolism for the inactive metabolites of THC, of CBD, of other cannabinoids with their lipophilic properties, that could lead to risks of drug-drug interactions further down the road, depending on how often someone uses, depending on if they smoke, depending on if they take edibles. It's something that patients consider because sometimes it's not as benign as you take something by mouth, you cleared it out. There's something called half-life that, well, you can calculate the rate of how long it stays in the body and how long it takes for your body to clear half of the active metabolite, but there's still also inactive metabolites that could lead to risk of drug-drug interactions or even lower the threshold of outcomes like heart rate increasing and other things that are tested for.
Thank you. Beautiful. Jordan, 30-second soundbite, and then we gotta wrap up the panel. I don't want to upset the other moderators with our science shtick.
Listen, I would just say this. Maybe I misunderstood the guy's original question, but it seemed to me the question was about spontaneously high heart rate during COVID. And so, you know, wearing the doctor hat here, I would say, you know, playing the odds. The likelihood is that while COVID could do this and THC can do this, most likely it's something else. And the first thing I would think about is anxiety and panic attacks. And sometimes we have panic attacks that are only manifest through, you know, somatic or body sensations like elevated heart rate and palpitations. So, you know, I just would, you know, not jump to any COVID conclusions just because it's kind of on all of our minds. The fact that it's on our mind may very well be more to the point than the virus itself, and that we need to kind of take that holistic, somebody mentioned, holistic approach, and really remember that there may be many, many things going on here.
Thank you. Thank you so much. Okay, so rapid fire, guys and gals, sorry. Where can people learn more about you? What would you like to share? Call to action, real quick. I'm just gonna go visually. I'm gonna start. Monica's on this side right here. We're gonna go, I don't know if you guys said, but Monica, real quick, closing statement for our attendees. And
Okay. Well, thank you, Susan, for hosting us. Thank you to my amazing fellow panelists for just being your wonderful beacons of science and education. So my closing statement will be, I am participating in the 3rd annual digital cannabinoid-derived pharmaceuticals summit. The topic and focus of this summit will be pioneering the research and development of pharmaceuticals containing cannabinoid APIs. I am on the clinical development track. My lecture is entitled A Fact-Based Approach to Training Medical Providers on the Endocannabinoid System, Demystifying Common Myths and Misconceptions of Medical Cannabis. Ultimately, what I will be talking about is using a pharmacological approach focusing on the pharmacokinetics and pharmacodynamics to debunk common misconceptions, because I'm seeing without the lack of the endocannabinoid didactic curriculum that's exposed to medical providers, I'm still encountering during medical grand rounds and training series, like an in-service, like, I heard it was a gateway drug. And I was like, what? No, oh no, let's go back to the science and like go over that. And I'll also be focusing on polypharmacy, the issue of so many prescription medications and the more harmful outcomes that arise due to that, and how practitioners need more screening and education around the prevention of that. And also when you add in like cannabis, cannabinoid medicine, how that onto itself is such a multifaceted, heterogeneous plant medicine, and the prescribing cascade that comes from it. So I'm really excited to talk about all these topics. If you're participating in the summit, please let me know, reach out to me via LinkedIn, but I'm really excited, even though it'll be digital, it's supposed to be in Boston, but I think it'll be a great time.
The attendees will be lucky to see that presentation. Dr. Apgar, what would you like to leave our participants and attendees with today?
Oh my God, that's a really open-ended question. You know what? I love this. Thank you for elevating the bar. Thanks for helping all of you to push the needle forward. I appreciate it. If anybody wants to find me, probably just www.greenhousewellness.com, or you guys can email. Anybody can email me. I'm not picky. Leslie@greenhousewellness.com. You can kind of find all the things that we're doing. Actually, tomorrow is Friday, I think. Oh my God. Friday, we're actually teaching a course at Howard Community College on cannabis, which is awesome. So I'm going to do the science part of it. I really should have Monica, now that she can remote in, I should have her teach it. But that's what we're doing. So we're starting to educate. So, you know, you can find me whenever you want.
Wonderful. That is so cool about the teaching at the college. That is really cool. Awesome. Awesome. Dr. Olga, what would you like to leave the audience with? Your final thoughts.
Well, first off, again, thank you very much, guys, for doing it. This is absolutely amazing. Thank you, Susan. Thank you, my fellow panelists. So as I said, I really want everybody to get fingers and toes crossed, because we have done this much to address every possible comment. And plowing through, because we have actually proven that indeed what we say is true and it actually works. which is great. And on the other hand, I would really want to draw your attention of my fellow panelists, as well as maybe your colleagues. We are working on preparing 2 special issues, one for the International Journal of Molecular Sciences on medical cannabis, as well as we are also working with colleagues Peter Rubin and Sylvia Brill in preparing an issue for Frontiers in Molecular Sciences, again, also on medical cannabis. And we would really like to invite people to contribute research articles, review articles, perspectives, commentaries, because we really need to have a very solid scientific background, as well as background for clinicians, for researchers, as well as for general public and students for education. That would be very important.
Thank you. Please send me a link to your call for papers. I'd be happy to share that with my network. Jordan, you got 15 seconds to make the dunk here. What do you want to leave the audience with?
All right. Number one, I want to thank the audience for coming and everybody for hosting and being wonderful panelists. If anybody wants to reach me about basic science or practice of medicine, that sort of thing, go to my website, inhalemd.com. You can reach me through the website. You can also read over 100 articles that are there on the various subjects. But most importantly, I want to draw your attention, as Jehan did at the beginning, to the Association of Cannabis Specialists, which is available on the web, cannabis-specialist.org. We're an international group that focuses on providing education and advocacy for medical cannabis patients to lawmakers and obviously to clinicians as well. And I could go on, but you gave me 15 seconds, so I'll shut up now. Thank you again.
Thank you so much. Just going to wrap things up in like 10 seconds here. I love all you for attending. This is so nice to see so many participants in the study and my lovely panelists showing up and bringing their A game. I'm just going to leave with a non sequitur, a mind munchie, food for thought, if you will. To paraphrase a quote, experts make predictions that are either right and prove everyone else wrong, or they are wrong and again, prove everyone wrong as well. Thank you so much for your time and attention. I apologize for going over. Susan, this was another terrific opportunity for us. Thank you so much.
Thank you so much, Jehan. This was an amazing panel, and it will be available very soon, at least by Monday. I'll make sure you all get it, and we'll blast it out to people that were not able to attend this morning. So I'm going to turn you folks into attendees so that you can continue to post your links in the chat. And everyone, all you attendees, go grab some water, move around a little bit. We've got a panel that I know you're not going to want to miss at 10:15, bridging the gap between legacy operators and the new market. Thank you, panelists. Thank you, Jehan.